able to is being able to have more of an understanding of the language itself. So there are some people who suffer from a Wernicke's and they know what they're saying is absolute gibberish. And then there are other folks like, Byron, he thinks he's saying what he's really saying, but he's not saying what he thinks he's saying. Does that kind of make sense? So it just sort of depends on how much damage has been done to the brain. Any questions on that? So Broca's versus Wernicke's, right? So the anterior portion of the MCA causes Broca's aphasia if it's blocked. The posterior portion of the MCA would cause Wernicke's. So Dan, what would cause someone to know that they're not speaking gibberish? Well, think about the fact that when you have the stroke, it doesn't normally just affect one part of the brain, right? So if his stroke is affecting cognition and language, he would not be able to know that he is speaking gibberish, right? But if you have an area of the brain that's disrupted only because of the language center and cognition is just fine, then you would know you're not speaking correctly. So it's the area of damage caused by the stroke. So the stroke itself is the dead area, right? So the stroke is the event that caused death to the tissue, okay? And depending on how much tissue has died or is damaged would depend on how much of destruction you have and how little language you would able to be processed or you would able to process, basically. So expressive aphasia is Broca's, receptive is Wernicke's. Yes, Shannon. Yeah. Okay. So, so Dan asked this really interesting question, right? About, whether or not you know. So one of my very good friends, she suffers from some type of like crazy, like some kind of disruption of blood flow to her brain. I can't remember exactly what it is. But anyway, so one day she's doing gardening. She's older, right? So she's doing gardening and like she calls to her husband and she's just like talking to him straight Wernicke's. And she's also an MD. So she realizes she's speaking in Wernicke's and she's like, what the fuck is going on? You know what I'm saying? But her cognition was just fine, but she was able to know that she was going through a Wernicke's aphasia. So she goes inside and she calls she calls the ambulance to come for her because she's like, damn, if I'm having a stroke, I need to get that checked out like ASAP. Turns out she wasn't having a stroke. It was something else that was going on, causing for her to have disrupted blood flow to her language center at the particular time, but it wasn't a stroke. Yeah. So just to like, okay, so Andrew, so the individual is not understanding what's being asked of them, or it's just that it's both. It's both, Andrew. So it really depends on the degree of damage, but but essentially it's both. So it can be one or the other or both. I know I have really interesting friends, Dan. You're absolutely right. You know why? It's because all my friends are very different and they span a very large age group. That's why. Yes. Okay. So sometimes stroke happen in the brainstem. So if you have stroke happen in the brainstem, you know what's in your brainstem? Little tiny space, lots of function. Cardiovascular function, respiratory function. So someone who suffers from a stroke in the brainstem is more likely to face a very complicated recovery or death, right? And then also think about that, depending on where the stroke happened, if it's above the desiccation of the pyramid, which is the crossing of the pyramids, if it's above the crossing, it happened contralaterally in the body that you see the symptoms. But if it's below the crossing of the pyramids, then it's on the same side. Okay. Okay, what about cognitive deficits, right? So, patients can suffer from cognitive deficits like spatial relationship skills or their memory or their judgment or their personality based on the stroke. If the stroke happens in the frontal part of the frontal lobe, like we talked about, like if it happens in the executive suite, in the cerebral cortex, you start to have cognitive deficits, right? So spatial relationship skills are kind of like knowing where one thing is in relationship to another and being able to move or manipulate those two things then. Yeah. So overall, you know, when we're thinking about stroke, we have to think about where is it happening in the brain, and where it's happening in the brain will really depend on our symptoms, right? And depending on how much of the brain has died and how much is still recovering from hypoxia and ischemia will depend on the overall recovery. So the stroke happens in the blink of an eye, but the recovery can be very long. Yeah. All right, so let's do this case together. All right, we've got a guy, he's got a wife. They come to the ED because he was having difficulty speaking. He was weak, had numbness on the right side of his body, right? He's hypertensive. He's taking Enopril, which is an ACE inhibitor. He's taking Inderal, which is a beta blocker, right? But he comes in to the emergency department, an ambulance took him in. His wife called the ambulance. Okay, they take his vitals. His blood pressure is 172/96. His pulse is 106, temperature 98, respiratory rate 22. He's got diminished strength in his right hand and right foot, diminished movement of right arm and leg, and slurred speech. Okay, they do MRI, CT scan, they run an EEG on his brain, they do an ECG for his heart. His ECG shows that he has atrial fibrillation. 6 hours later, his symptoms resolve. What do we think this guy has? Is he having a stroke or is he having a TIA? How do we know it's a TIA and not a stroke? Because the issue resolved. Okay, so now let's go back to Andrew. Andrew thinks it's an embolic stroke. Now, Andrew has really picked up on something very important in the text, right? In this particular case, he's not having an embolic stroke yet. However, what did we notice? So what did you notice why you said embolic stroke, Andrew? You noticed something very important. He has the AFib, exactly, right? So more than likely what's happening with this particular guy is he having a TIA because of his AFib. He probably has an embolism which has caused lodgement in the cerebrum arteries, right? However, not enough to cause necrosis. Does that make sense, guys? So that's really good that you picked that up, okay? So we know it's a TIA because his issue resolves after a few hours, but Andrew made a very, very key observation that he probably is suffering from some type of embolism leading to his TIA, okay, because of the AFib. So I'm with you on that, okay? So I have another question for you guys. Is it important to note that he has all this right side weakness? What does that tell us? He has this. So because his legs are affected, we know that it's affecting not only just his MCA, but his ACA is probably affected as well, Ryan, yes. So his obstruction is definitely before the split. But what about this left side, right-sided issue? What does this mean to us? Well, the lefty side of the brain is affected. That's right. And how do I also know the left side is affected? Because of what? There's something that's key to the left side that makes his language. Very good. All right, absolutely. I agree with you on that. So we give him this anticoagulant therapy. Is that a good idea? Are we sure about this? Yes. How do we know? Why are we sure? Because for one, the issue resolved, letting us know that it's probably ischemic related. We do the scan and we see that there's no bleeding. Absolutely. So we're like, hey, we see that there's probably this obstruction. We work with that. Absolutely. Very good, guys. Okay, I have another one for you guys. How about this? This is Mr. Jones. He's 72. He comes in, he's got right side weakness, slurred speech. He's got hypertension, type 2 diabetes, and he smokes a pack of cigarettes for the past 55 years. They do his scan. His scan shows intracranial hemorrhage. What kind of stroke we think Mr. Jones have? Hemorrhagic, okay, very good. Why do we think he's got a hemorrhagic stroke? What is his risk factors? What lets us know it's hemorrhagic? The hypertension is the risk factor, right? The smoking, but the primary risk factor for sure is the hypertension. Not as much the diabetes mellitus. The diabetes mellitus wouldn't really add to his intracranial hemorrhage as much as the hypertension for sure. Smoking can complicate it, right? But I would say hypertension would be the prime risk factor that he's suffering from right now. Okay, so for him, we know, even though he's got, and I like this case study because it throws a whole bunch of stuff at you, right? Making you feel like, damn, you know, this dude, he's got type 2 diabetes and he smokes, you know, what's going on? Maybe it's ischemic. But doing the CT scan makes us know, even though he's got a lot of risk factors for an ischemic stroke, he's actually having a hemorrhagic stroke right now. This dude needs help, right? Because he's got risk factors for both ischemic and hemorrhagic stroke. But right now, he's just suffering from hemorrhagic stroke. Does that make sense, guys? Perfect. Okay. So if we move off of stroke, but still do bleeding, we can do cerebral aneurysms. So the cause of his hemorrhage is probably his hypertension, Talia. So aneurysms actually come from, you know, high blood pressure as well, right? When the vessel is, if the vessel is very weak, what's going to end up happening is the vessel wall is going to be thin. And then vessel wall, when it's thin, when the blood is passing through in the thin area, it will begin to pool. Okay, so when it pools, it begins to balloon out. And when it balloons out like that, it causes for the aneurysm. So the aneurysm itself is not the problem. The problem really is when the aneurysm tears or bursts, right? So the most common part aneurysm, I would say, is a berry aneurysm, which looks like this, where it kind of buries out, all right? So the idea is that you're going to want to clip the aneurysm or coil the aneurysm so that the blood will clot. So when the blood is flowing through, it doesn't get into the aneurysm, because the more it increases in size, the more it is at risk for, you know, tearing and bursting. So warning leaks let us know that the aneurysm is about to rupture. And those warning leaks produce a headache like you've never had before. Like there is no describing this headache, right? The patient becomes very sensitive to light. They'll probably have nausea, vomiting like crazy, and they'll have this stiff neck. Okay, guys? So typically what you want to do, so for example, aneurysms are genetic. My uncle, my dad's brother, died from an aneurysm when he was in his early 40s. Okay, all his kids need to be checked for aneurysms because it's a genetic disorder, or it can be a genetic disorder. So here's a joke. It's not really funny at all, but none of my cousins have done this MRI. Last year, one of my cousins, hey, one of my cousins actually ended up in the hospital due to a leaking aneurysm. So all along, we know that my uncle died from the aneurysm. All along, we know that my cousins need to get checked. None of them got checked. And what happens last year? One of them ends up in the hospital with a leaking aneurysm. So guess who's getting checked now? All of my cousins who come from my one particular uncle, right? So hypertension obviously puts you at risk, right? My cousin, he was suffering from hypertension at the time. And you know what's the interesting thing? His dad died just a little bit over 40, and he had this aneurysm last year. Guess what? You know how old he was last year? 39. Ain't that some shit? Yeah. So, so here you go. So once the aneurysm ruptures, it's going to cause for leakage into the area, and the leakage into the area increases the overall intracranial pressure, right? So just like Katina said, you know, her grandma died from an aneurysm, so her dad has to get checked for one, and that's really the way it works. Absolutely. All right. You know, Shannon, it's not really just the younger people. It is everyone, but you do see it in younger people. Like it doesn't hide in an older generation. It can happen as early as a teenager. You know, I remember my Spanish teacher in high school. She died from an aneurysm too. She was just sitting down and boom, damn, she just fell and died. It was nuts, you know. So yes, you can actually have it without the leaking warning, like if it just ruptures. Leaking is good. Leaking means that the aneurysm is full and is about to burst, but you can have it where it gets full and just ruptures immediately. Yeah, it's really scary. I would have to agree. Yeah, it's scary. Yeah, so you want to make sure you stabilize that aneurysm. If you are prone to aneurysms or your family members are prone to aneurysms, you want to get those scans so you can see if they're there, clip them, or embolize them. So risk factors are going to be patients who suffer from hypertension, right? Because having the high blood pressure will cause for weakened arteries, and weakened arteries can lead to aneurysms. And it also is a genetic predispositions. In the genetic predisposition could be to hypertension as well, or just the weak vessels. Another thing is patients who have like, what you call it? They've got genetic disorders where the vessels themselves are not formed properly, right? That can put you at risk for aneurysms too, right? Having some type of blood vessel disorder would definitely put you at a risk for an aneurysm as well. All right. Yes, yes, yes. Lovely. You have to mention everything. Very true. All right, so let's get out of this blood and let's get into these infections, right? So typically when you're talking about organisms gaining access to the CNS, your blood-brain barrier is either compromised in some kind of way, or there's some opening, why is my brain not working right now? Like a crack, yeah, like there's some kind of fracture in the skull or in the spine or something like that, where they can get direct access. Or it could be a situation where you have a maternal fetal exchange, because a fetus blood-brain barrier is not very good. It's very compromised. It's not very mature. Or it could be you've got ear infections, sinus infections, respiratory infections, and then they head to the brain. You name it, it's possible. So it's either you're going to have inflammation of the meninges, which is meningitis, or you're going to have some type of inflammation of the actual brain tissue, the actual brain parenchyma, which is encephalitis. You could also have a cerebral abscess where you have like a focal area of collection of pus. So something like meningitis tends to be bacterial, but I will say this, if you get vaccinated and you get meningitis, you probably have a viral meningitis instead. So, Neisseria is highly contagious, and it's one of the leading causes of meningitis in adults. But, like for example, you guys go to UCF, so more than likely you're vaccinated for Neisseria because they don't want to let you on campus where you've got like 70,000 other people that you're interacting with and you can breathe on them and give them Neisseria, right? Some kids get vaccinated for H influenza, so that helps to keep down childhood meningitis. But, bacterial meningitis is more, I would say, more common or more likely to occur. But with vaccinations, viral meningitis has been on the rise because we're able to control the bacterial meningitis. And then encephalitis is actual inflammation of the brain tissue. So a meningitis could lead to an encephalitis if the infection leaves the meninges and gets into the brain tissue, yes. So, bacteria can reach the CNS in all the different ways I explained to you before. But once they start to cause the inflammation, you get a lot of accumulation of exudate, like pus, right, from all the inflammation. And that exudate can actually lead to obstructive hydrocephalus, like we talked about yesterday or the day before. Okay, so if someone has meningitis, we've got to get rid of the infection, right? We have to treat with antibiotics intravenously. We've got to give them supportive care. We really have to decrease the inflammation the best as possible, right? Typically when someone has meningitis, right, you'll tend to find that they either had like an infection that was upper respiratory tract or an ear infection or something to pass on the microorganism. And then they tend to have this very stiff neck, very painful because the meninges themselves start to because they're inflamed, they rub against each other and it causes that stiffness in the neck itself. So I would say viral meningitis is milder than bacterial meningitis. You know, I know you say I have a lot of stories, and I don't know why I have all these stories, because I feel like I'm a recluse who doesn't really have a lot of friends, but I know a lot of people, right? So my cousin, oh, this is a sad story. My cousin's girlfriend died 2 years ago from bacterial meningitis. Yeah, she was in her late 20s. She got a meningitis, she got an infection, which complicated into meningitis, and then she died 2 years ago. Yeah, now that I think about it. So risk factors would be people who are like living in, you know, community settings, so the bacteria can spread very quickly, especially by a respiratory route. People who are immunocompromised, who have AIDS, anyone on an immunosuppressant drug, that can cause for, you know, the immune system to not be as working as well as it's supposed to, and compromising you for some type of infection. So encephalitis is an inflammation of the actual brain tissue itself. You know, typically it's viral, and it comes on abruptly, develops very rapidly. You can see this inflamed area of the brain right here. Tends to start with fever and headache, and then the symptoms just like rapidly worsen over time, become seizure, confusion, loss of consciousness, even a coma. But as you can see here, right, you can see the inflammation on these scans for these individuals. All right, so you want to control the symptoms, control the fever, control the seizures, give as much fluid resuscitation as possible, and treat for the actual infection that's leading to the encephalitis. So herpes simplex virus gets into the brain because, remember, herpes simplex virus is what? A virus that can go latent. And where does it like to go latent? In the neurons. So that's like one shot heading towards the brain. Yeah, absolutely. All right, last but not least, that leads to our cerebral abscesses, right? So abscesses are like focal collections of pus in the brain tissue. It could be due to the fact that, you know, you had a sinus infection and it moved into the brain, or an infection of the mastoid process, right? That likes to happen a lot. And it moves into the brain. You know what's the worst part? When you go to the dentist and you get an infection because you did a tooth extraction, and then you wake up with an abscess in your brain. That's a problem, right? So you get this acute you get this localized collection of of pus in the brain tissue, and these abscesses themselves need to be either drained or removed, right? So you'll notice that the abscess itself is filled with pus and neutrophils and debris and inflammatory tissue. And, you know, because it's an abscess, the core is usually liquefied, right? So the pathogens can enter the brain via wounds, or maybe from some kind of infected structure nearby, like the ears or the sinuses. That's a great way, or the jaws. That's a great way to get a cerebral abscess. So you need to drain the abscess or excise the abscess, and of course, treat the patient with antibiotics. Okay, any questions on that? Yes, remember knowing the specific pathogens, especially like for the infections, would be good. No problem. All right. I know, right? Just can't type. Any other particular questions? So, you know, knowing things like your different organisms, you know, make sure you guys know how to differentiate between the different type of strokes, the different type of aphasias, the different type of obstructions that lead to the different type of aphasias, you know, that type of thing would be good. Yes, let's do that together for Ashley, right? So if you have a hemorrhagic stroke, you have a stroke that is because you have bleeding of a vessel, right? So the vessel has ruptured and you're bleeding out of the vessel into the brain space. So when you're looking at a hemorrhagic stroke, it would look something like this. See how you have a collection of blood all in the space, right? So it causes for hematomas, which increase your intracranial pressure. Okay, so something like hypertension, or if you have some kind of clotting disorder, that can put you at risk for a hemorrhagic stroke. An ischemic stroke is caused because there's some type of obstruction in the vessel, like an atherosclerotic plaque or blood clots or an emboli, something that's obstructing the blood flow. If there's obstruction of the blood flow, no blood can get to the target tissue, the tissue will die. If you have a hemorrhage, no blood can get to the target tissue, the tissue will die. When you've got a stroke, the tissue is dead. Is that good, Ashley? So risk factors for hemorrhagic stroke would be anything that increases the blood pressure that causes rupture, okay? Or anything that can cause leakage or rupture of a vessel, aneurysms, anything like that. Ischemic stroke risk factor is going to be anything that can cause for obstruction, anything that puts you at risk for atherosclerotic plaque, anything that puts you at risk for a thrombus or an emboli. Very good. Any other questions, guys? What type would hypertension be a risk factor for? Well, you tell me at least. What is hypertension? Yeah, hypertension is what? An increase in your blood pressure. Which of the two do you think would be caused because of an increase in the blood pressure in your vessels? What do you think? Absolutely. Very good. Andrew, what's your question on the mic?
So in the case studies that we were going over, you said that the diabetes mellitus wouldn't really increase his risk for an ischemic stroke, but
No, no,
does
no, 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 no. The diabetes mellitus would increase his risk for an ischemic stroke, not as much a hemorrhagic stroke.
okay, I got
Yeah,
you. Thank
yeah,
you.
man, definitely. Yeah. So one of the reasons why this case study is kind of good is that it's tricky in a way because he's got all type of risk factors to make you think he's got a ischemic stroke, but his CT scan tells you otherwise, right? Because this guy coming in with his type 2 diabetes and his issue with smoking all the time, right? Even with his hypertension, you may not go to think that hemorrhagic is straight, right? You wouldn't think that based on his history, right? Yeah, he got the hypertension, but you would think the complications of the smoking and the type 2 diabetes would increase him having plaques more than anything else. Until you do his CT scan and you're like, well, it's a good thing I didn't give him that TPA just yet, right? Any other questions? Absolutely. So Elise, do you understand why hypertension is a risk factor for hemorrhagic stroke? Cool. Anything else, guys? Remember your quiz is 43 and 44. And then when we come next week, we'll do 45. And then we'll be done with the unit. Can you imagine? Time is flying. Before you know it, it's Thanksgiving, and then it's finals, and then we're done. It's all over. All right, perfect. Okay, guys, so I will see you next week. Have a great rest of the weekend. Graduation can't come soon enough, right? Christmas break can't come soon enough. What are you talking about? All right, guys, you have a good rest of the week and rest of the weekend. You enjoy yourselves, and I will talk with you next week. All right, take care, guys.